Congress of Endoscopy, Hepatology, and Gastroenterology. Let's reveal the secret behind the pain of our patient, who is 32 years old female, married with 2 offsprings, the youngest 3 years old, and she is a housewife with no special habits of medical importance. She presented to us complaining with long-standing upper abdominal pain. For how long? She has been complaining of abdominal pain for 6 years with insidious onset and progressive course. The pain is mainly epigastric, dull aching, with no specific radiation, and is aggravated by meals and relieved during fasting. So, she was asked to be tested for H. pylori antigen in stool, and she was diagnosed as H. pylori gastritis, for which medical treatment was prescribed with successful eradication of H. pylori. However, her abdominal pain is still persistent with the same features. There is no history of vomiting, diarrhea, bleeding per rectum, or constipation. There is no history of oral ulcer, joint affection, or symptoms suggestive of autoimmune etiology, and there was no history of fever. The review of other systems was unremarkable. During clinical examination, her vital signs were accepted. Her body weight was 51.5 kilograms with a height of 160 centimeters, and body mass index was 20.1 kilogram per meter square. No significant physical findings were noted. So the problem list in brief is long-standing epigastric abdominal pain with intimate relation to meals, exaggerated with eating, and relieved during fasting. What should we think about? There is a very wide spectrum of diseases that can cause chronic upper abdominal pain, starting from chronic cholecystitis, functional biliary pain, primary sclerosing cholangitis, passing through the peptic ulcer disease, GERD, dyspepsia, gastritis, whatever the cause, gastric malignancy, chronic pancreatitis, or splenic affection, reaching to miscellaneous causes as the IBS, IBD, celiac disease, abdominal aortic aneurysm, or hypercalcemia. So we have to detect which of these can be the cause. Passing through the investigations of our patient, her blood count showed normocytic normochromic anemia with normal leukocytic and platelet count. Her liver functions are normal, bilirubin and liver enzymes and albumin. Her kidney functions are also normal with normal levels of electrolytes. Lipid profile was normal. Other investigations, including fasting glucose, ESR, C-reactive protein, and TSH, are also accepted. Her pelvic abdominal ultrasonography was normal. Normal spleen, normal liver, normal gallbladder, and other intra-abdominal structures. So we proceeded for upper GIT endoscopy. The esophagus showed us few linear erosions at the distal end. Regarding the stomach, the mucosa of the fundus and body were normal. The mucosa of the antrum was hyperemic, and arterial biopsies were taken for histopathology. The first ring in the chain for our diagnosis was present in the duodenum. The lumen of the second part is seen partially compressed with visible pulsations at the posterior duodenal wall that may suggest superior mesenteric artery syndrome. However, biopsies were obtained from second part for exclusion of celiac disease. And the result of the biopsy was mild duodenitis with preserved villi, chronic inactive gastritis of mild intensity, and indefinite for H. pylori. What should we do next? Starting from the superior mesenteric artery syndrome, we had to perform color duplex of the abdominal vessels that showed patent curved celiac trunk with discrepancy between the peak systolic and end diastolic velocities during fasting and postprandial. The curved course, including a mild stenotic lesion after the mouth, causing 48% stenosis with mild post-stenotic ectasia. So we had to proceed for multi-slice CT scan of the mesenteric vessels. And as seen in this figure, the celiac artery origin shows mild osteoproximal kink concave upwards with acute angulation curvature and mild post-stenotic dilatation. So we had reached our diagnosis for this case, and the findings are highly suggestive of median arcuate ligament syndrome. In brief, median arcuate ligament syndrome is also called celiac artery compression syndrome, and Dunbar syndrome is more likely to affect young adult females presenting with upper abdominal pain, frequently made worse with eating, weight loss, nausea and vomiting, upper abdominal bruit. Other non-specific symptoms as palpitation, chest pain, diarrhea, or constipation are also present. The causes of the abdominal pain are either due to compression of blood flow from the artery, nerve irritation, or steal phenomena where blood flow from superior mesenteric artery supplying the stomach and the liver can cause pain. The nerves in the area of celiac artery are thought to be overstimulated, leading to arterial spasm. Compression of the nerve causing interference of the neuroenteric pain pathway, leading to hypersensitivity and pain. For the diagnosis, because there are many causes of chronic abdominal pain, we have to follow the following sequence. blood work and inflammation markers, abdominal ultrasound, upper endoscopy and biopsy, then mesenteric duplex with diagnostic criteria for celiac artery compression if peak systolic velocity more than 200 and end diastolic velocity more than 55 centimeters per second. And finally, to confirm, we have to perform CT mesenteric angiography or MR angiography. It is to be differentially diagnosed with functional dyspepsia, abdominal migraine, IBS, and rumination syndrome. The treatment simply is surgical release of celiac artery from compression with simultaneous removal of the nerves, with a success rate ranging from 60 to 80%. However, in case of recurrence or persistence of pain, we have to follow the following algorithm. We have to repeat the mesenteric duplex ultrasound. If there is significantly elevated velocities, proceed for angiography and possible angioplasty. If there is normal celiac artery velocity, so we have to perform CT angiography for possible intra-abdominal pathology post-operatively. If a lesion exists, we have to surgically resect it. If no lesion, we proceed for celiac plexus nerve block. And thank you.